Hello students, good evening everyone. I am Dr. Anagha and today we are going to continue with twin pregnancy. So in today's session we are going to cover diagnosis, maternal as well as fetal complications and its management. So let us begin with diagnosis. Of course, diagnosis we are going to do it by ultrasound, but if in case we have to do it clinically, then for that most important thing is history taking, right? So we are going to ask the patient whether there is any use of ovulation inducing drugs or whether there is any family history of twinning, as there is hereditary predisposition, right? Now the patient will come and tell you that there is an increased frequency of nausea and vomiting. Also in later parts of pregnancy or like from second trimester onwards, there will be mechanical distress, and it will be due to over distension of the uterus. That will lead to palpitation, shortness of breath, and also swelling of the legs. Now, if you do abdominal examination, then their fundal height will be more than period of gestation, which is quite obvious, right? Then you will be able to feel too many fetal parts, and also you will be able to hear FHS at two distinct locations. Okay, now moving forward, let us understand the complications. So, maternal complications are solely dependent on the number of fetuses present inside the uterus. It is not dependent on chorionicity or any other thing, but only on the number of fetuses present inside the uterus. More the number of fetuses, more will be the maternal complications. So, as we have seen, there will be an increased frequency and severity of nausea and vomiting. Anemia will be present because as there are two fetuses, their requirement will be more. Now, preeclampsia. The risk of preeclampsia is 3 times increased than in singleton pregnancy. Why? Because abundant of chorionic villi are exposed in twin pregnancy, right? So this will lead to hypertension and preeclampsia. There will be polyhydramnios, and polyhydramnios will come with its own set of complications. Okay, antepartum hemorrhage can be there due to placenta previa. As there is a bigger placenta, it might encroach into the lower uterine segment, right? And abruptio placenta can be there because you know what happens, like if there is premature rupture of membranes, then this sudden, actually this amniotic fluid keeps the pressure maintained inside the uterus, right? Now this sudden release of pressure in the uterus will lead to abruptio placenta, and that will lead to antepartum hemorrhage, right? Now there could be preterm birth because of over distension of uterus and polyhydramnios. It can lead to preterm birth. Also preterm premature rupture of membranes. Then increased operative interference will be there. Why? Because due to malpresentations. Malpresentations can lead to more frequent C-sections or forceps delivery. So there will be increased operative interference. Now postpartum hemorrhage can be there due to a tonic uterus, and this atonic uterus will be present due to over distension of uterus. Also, as there is a bigger placenta, it can expose more of the uterine sinuses, and that can also lead to postpartum hemorrhage. Now let us understand the fetal complications. Prematurity, which is most common fetal complication, it will be due to preterm birth. Low birth weight, again due to prematurity. Rate of abortions is more in twin pregnancy and specifically in monozygotic twins. Fetal abnormalities can be present. They are also more in monozygotic twins. Discordant twin growth. Now, some degree of discordant growth is normal, but if there is a difference of more than 20% between two fetal weights, then it is a pathological discordant twin growth, right? Fetal growth restriction, as there is a small space, actually space is not small, since the space is only for a singleton pregnancy and there are two fetuses growing inside that space. So obviously there will be fetal growth restriction, and also due to the increased requirement of two fetuses, sometimes mother may not be able to fulfill that requirement, and that can lead to fetal growth restriction. Okay. Now, let us understand the complications which are specific to monochorionic twins. Why complications are specific to monochorionic twins? As we have seen in last session, that fetal complications are dependent on chorionicity, right? So, in case of dichorionic diamniotic twins, complications will be less. Why? Because there are two different chorionic cavities, two different amniotic cavities. So even if something happens to one twin, another twin won't be affected that much because it is growing independently, right? But in case of monochorionic diamniotic, complications will be more, and it will be highest in monochorionic monoamniotic, because there is sharing of placenta, and this sharing of placenta can lead to anastomosis between the fetal vessels, and it will lead to further complications, right? So which are the complications specific to monochorionic diamniotic? It is twin to twin transfusion syndrome, twin anemia polycythemia syndrome, and twin reversed arterial perfusion. We are going to see in detail about each complication further. And the complications which are specific to monochorionic monoamniotic are more dangerous, and there is an increased fetal mortality in monochorionic monoamniotic twins, right? Because there could be cord entanglement. As you can see in this image, cord can get entangled, and interlocking of twins. As there is a single amniotic cavity, limbs of the twins like hand can get interlocked between each other, or lower limbs can get interlocked. So interlocking of twins can be there in monochorionic monoamniotic twins. Now, let us understand each complication in detail. First one is twin-to-twin transfusion syndrome. So, the cause of twin-to-twin transfusion syndrome is deep artery-to-vein anastomosis. Now, here what happens? Umbilical artery of donor twin is connected to umbilical vein of recipient twin. So what happens here is that deoxygenated blood will come from the umbilical artery of donor twin. It will go into the placental cotyledon and it will go towards umbilical vein of the recipient twin. So there is an unidirectional blood flow, and that will lead to anemia in donor twin, hypotension, oliguria. Why oliguria? Blood flow will be less towards the donor twin, right? And more in recipient twin. So if there is an acute blood loss, the first organ to shut down is obviously kidneys, because as there is a low blood volume, it will be given to most important organs, right? So brain will be provided first, as it is the priority, and last one will be your kidneys. So there will be decreased renal perfusion, and this decreased renal perfusion will lead to oliguria, and this will lead to oligohydramnios. Why? Because in later part of pregnancy, amniotic fluid is mainly consist of fetal urine, right? So as there is oliguria, it will lead to oligohydramnios. Circulatory insufficiency will be present. Growth restriction, as the blood flow is less, there will be growth restriction in donor twin. And if it continues, there can also be renal failure, and even it can lead to cerebral palsy. In severely affected twins, it can lead to cerebral palsy, and ultimately fetal death can also occur. And in recipient twin, as there is more blood flowing towards the recipient twin, it will become polycythemic. There will be hypertension, polyuria because renal perfusion is increased. So it will lead to polyuria, and polyuria will lead to polyhydramnios. There will be circulatory overload, and this circulatory overload can lead to heart failure in recipient twin, right? It can also lead to hydrops fetalis and ultimately fetal demise. So twin to twin transfusion syndrome is specific in monochorionic diamniotic twin, and the cause is deep arteriovenous anastomosis. Okay. Now let us see this ultrasound image of TTTS. As you can see, this is your donor twin. This is just a minute. This is your twin. So this is your donor twin, which is completely stuck. There is no presence of amniotic fluid. It is completely devoid of fluid. So this is stuck twin, which is your donor twin, and this is your recipient twin, and this you can see amniotic cavity where there is polyhydramnios. Alright. Now there is grading of severity of twin to twin transfusion syndrome. First stage is when there is oligohydramnios in the donor twin and poly in the recipient twin. So that is your first stage. Now, if this continues, in second stage, there will be no visualization of the fetal bladder in the donor twin. And even after this, if it continues, there will be abnormal umbilical artery Dopplers in third stage. In fourth stage, there could be hydrops fetalis in one or both the fetuses. And at last, there could be death of one or both of the fetuses. So this is the grading of severity. This is known as Quintoros staging. So what is the treatment of twin to twin transfusion syndrome? Fetoscopic laser ablation of the vascular connections. So we are going to use the fetoscope, and by using laser we can cut the vascular anastomosis which is present, right? So this is the only treatment, and it is currently not available everywhere, as we have to use fetoscope and we need a very skilled surgeon for this. Second complication is twin anemia polycythemia syndrome. Now the cause for this is tiny artery to vein anastomosis. In TTTS also there was artery to vein anastomosis, but it was deep anastomosis. And in case of twin anemia polycythemia, it is tiny arteriovenous anastomosis, right? So it is a slow and chronic transport. of RBCs from one fetus to another, and there is no fluid differences as it was present in TTTS. So the donor twin will become anemic as it is transporting the RBCs to the other fetus, and as a result recipient twin will become polycythemic, and it can also develop after treatment of TTTS because during laser ablation it might happen that some tiny arteriovenous anastomosis remain like that only. So after treatment of TTTS there can be development of twin anemia polycythemia syndrome. Okay. So as you can see in this image, this is your donor twin which has become pale and anemic, and this is your recipient twin which has become polycythemic. Alright, so let us revise or let us understand what is the difference between TTTS and TAPS. So the mechanism here was large arteriovenous anastomosis, and in twin anemia polycythemia syndrome, it is a tiny or very small arteriovenous anastomosis, right? Here the onset was acute, here it is gradual and slowly occurring, or slow transfusion is there, so it can be chronic and gradual. Here amniotic fluid differences was present. It was oligo sequence was present in twin to twin transfusion syndrome, but here in anemia polycythemia syndrome, fluids are normal in both the sacs. Okay. Here donor twin was becoming donor twin was having oliguria and growth restriction. Here donor twin will become anemic. Here recipient twin was having polyhydramnios and polyuria. Here recipient twin is going to have polycythemia. Alright. Now the last complication, twin reversed arterial perfusion. Now in this case what happens? There is a large artery to artery anastomosis. So the cause for twin reversed arterial perfusion is large artery to artery anastomosis. Now in this case what happens? Umbilical artery of donor twin is connected to the umbilical artery of recipient twin. So in this case deoxygenated blood will be carried from fetus to the placenta, and that same deoxygenated blood will flow into the umbilical vein of recipient twin, right? Or you can say pump twin and the acardiac twin, because in this case what happens, as there is not enough blood supply into this recipient twin, upper body parts won't get developed, and there is no heart won't get developed in this recipient twin. Only the lower body parts get developed, right? So it is known as a cardiac twin. Now this pump twin is doing the work of both of the twins. It is pumping blood for that a cardiac twin as well as for itself. So there is an overload on the heart of pump twin. So it can lead to cardiac failure. It can lead to cardiac failure in pump twin as it is pumping blood for both of them. It can lead to overload and that can lead to cardiac failure. Okay. So this is your twin reversed arterial perfusion. Now, what happens if one twin dies inside the uterus? Now, if it happens early in gestation, like if it happens before 14 weeks in first trimester, then it will be known as a vanishing twin. It will get vanished by reabsorption. So there will be no problem. But if it happens in second trimester, then the surviving twin will compress that dead twin. It will become mummified and it will get stuck on the placenta. So it is known as fetus papacious. I'll show you the image. Look at this. This is your fetus papacious, and in second image you can see it along with placenta. So as you can see, it is completely mummified and compressed by the surviving twin, right? Now, if the death occurs late in pregnancy, then there is an increased risk of death of that another surviving twin and also its neurological impairment. Why neurological impairment in surviving twin? Due to sudden hypoxia. Because after death of one fetus, blood will flow from high pressure to low pressure. There will be sudden flow of blood from the heart of surviving twin towards the heart of dead twin, and that will lead to sudden hypoxia in surviving twin, and it can lead to neurological impairment, and also it can lead to death of the surviving twin, and it is more risky in monochorionic twins. Okay. Now, let us understand the management of twin pregnancy. So, if you want to deliver a healthy baby or if you want to get a successful outcome of the pregnancy, then the most important thing is early diagnosis of twin pregnancy and also early determination of chorionicity, amniosity, and also congenital malformations. So, to have a successful outcome of the delivery, we need to diagnose early. Now, fetal monitoring will be done by serial sonography. In case of monochorionic twins, as the risk of complications is more, we need to do this ultrasound every 2 weeks. And in case of dichorionic diamniotic twins, but if there is uncomplicated twin pregnancy, then in that case, we are going to do ultrasound every 3 to 4 weeks. Okay. Now, for a planned delivery, the timings will be for dichorionic diamniotic, it is going to be 37 weeks. We can wait till 37 weeks and then after that we can deliver. For monochorionic diamniotic, since it is a monochorionic pregnancy, we can wait till only 36 weeks. And in case of monochorionic monoamniotic, we have to admit the patient at 26 to 28 weeks and then do continuous fetal monitoring for fetal monitoring, and then at 32 to 34 weeks we are going to deliver monochorionic monoamniotic twin by C section. Okay. And in case of triplets, we can wait till 35 to 36 weeks. Now, all these timings are for uncomplicated cases. If in case any kind of complication arises, then urgent admission irrespective of period of gestation is to be done. Okay. Now let us understand how are we going to deliver the baby. So in case of if twin A is in vertex presentation and twin B is also in vertex presentation, then obviously we are going to go for vaginal birth. Now, if twin A is in vertex and twin B is non-vertex, then also we are going to go for vaginal delivery. Now, if twin B is in breech presentation, then we will deliver it by assisted vaginal breech delivery. And in case if twin B is having a transverse lie, then external cephalic version will be done to make the lie longitudinal. And then after the lie becomes longitudinal, we can do a normal vaginal delivery. But if external cephalic version fails, then we are going to proceed to internal podalic version, and it will be done under general anesthesia. And this is the only accepted indication of internal podalic version. Now, to do internal podalic version, you need a very skilled obstetrician, and everything should be ready in case of emergency. So in routine practice, if twin B is having a transverse lie, then it is better to go for C-section. So if it is asked in exams, then obviously your answer is going to be external cephalic version, and in case it fails, then you are going to go for internal podalic version. But in routine practice, it is better to go for C-section in such cases. Okay. And if twin A is in non-vertex presentation, then we are going to go for C-section no matter what is the presentation of twin B. Alright. Now let us take up few cases. A 28-year-old pregnant woman with monochorionic twin pregnancy at 22 weeks presents for ultrasound. Findings here are: one fetus is with polyhydramnios, another one is with oligo, and donor twin appears growth restricted. So poly-oligo sequence was present in, where was it present? It was present in twin-to-twin transfusion syndrome, right? And in that case, there was unidirectional blood flow from umbilical artery of donor twin towards umbilical vein of recipient twin. So, donor twin was appearing growth restricted, right? So, the correct answer is twin-to-twin transfusion syndrome. Another case, a pregnant woman with monochorionic twin pregnancy at 20 weeks shows the following ultrasound findings. One normal fetus, one fetus with no cardiac activity, and blood flow to abnormal twin is reversed. So, a cardiac twin is present. One fetus is normal, which we call it as pump twin, and abnormal flow to blood flow to abnormal twin is reversed. So it was present in reverse blood flow was present in twin reversed and arterial perfusion, right? In that case, what was happening? There was large artery to artery anastomosis, and the deoxygenated blood was flowing back to a cardiac twin, right? So the correct answer is twin reversed arterial perfusion sequence. Now, a 30-year-old woman with twin pregnancy at 28 weeks. 28 weeks is found to have death of one fetus on ultrasound. What complication is most concerning for the surviving twin in monochorionic pregnancy? Now, look at this period of gestation. This is the most important thing. It is occurring, death of one fetus is occurring in last trimester. And in case of monochorionic pregnancy, the risk for surviving twin will be neurological impairment due to, what was the reason? Due to sudden hypoxia. Right? So that's it for today. Thank you so much everyone. In next session, we are going to learn about antepartum hemorrhage. Okay? Thank you.